Have you ever actually thought about what might be taking up residence in the dark, hidden caverns of your skull?
Oh, that's a creepy thought.
Right, and I don't mean like your thoughts, your memories. I mean the physical empty spaces, the sinuses.
Yeah, the literal cavities in your head.
Exactly. Like, what if a totally routine, completely unremarkable trip to the dentist could, accidentally invite a microscopic squatter right into your face?
It is a genuinely unsettling thought, honestly. Right. We tend to walk around thinking of our internal anatomy as this, sealed, sterile fortress.
Right, like nothing gets in.
Exactly. But it's really more of an open ecosystem. And sometimes the outside world decides to just move in, unpack its bags, and set up shop.
Well, welcome to this deep dive. Today, we are immersing ourselves in a massive, highly detailed collection of medical data, surgical pathways, and clinical biology.
We're looking at some intense stuff today.
We really are. We are exploring the hidden world of fungal rhinosinusitis and the intensely precise, high-stakes mechanics of functional endoscopic sinus surgery, or FEFS, all the way up to full-blown facial reconstruction.
It is a fascinating spectrum to look at. I mean, you get a front row seat to the sheer diagnostic ingenuity required to figure out what is actually growing inside someone's head.
Yeah.
And then the surgical reality of how we physically evict it.
And our mission today is to translate that intense medical reality into a journey you can actually visualize. We're going to explore how seemingly harmless fungi turn into dangerous invaders.
Right. Yeah.
How surgeons map out the microscopic battlefield inside your head, and the truly incredible lengths modern medicine will go to in order to fix it.
Because to fight an invader, a doctor first has to understand exactly what kind of enemy they're dealing with. Not all fungal infections in the sinuses behave the same way.
Okay, let's unpack this. We start with the non-invasive fungi, right?
Yeah, and they generally split into two very distinct behavioral profiles.
Okay, let's look at the first profile, which goes by the deeply unpleasant name, the fungal ball.
It's highly descriptive, though. I mean, a fungal ball is exactly what it sounds like. It's a dense, tight accumulation of fungal fibers, usually from a genus called Aspergillus. And what's interesting is its geography.
Geography, like where it lives.
Yeah, it almost always sets up shop unilaterally, so just on one side of the face, and usually in the maxillary sinus, which is that large cavernous space right behind your cheek.
And the patient profile here really stood out to me. Like, we aren't talking about sick, vulnerable people.
No, not at all.
It typically affects older, middle-aged individuals who are entirely immunocompetent. Like, their immune systems are working perfectly fine.
Yep, completely healthy immune systems.
But the trigger that actually kicks this off, the notes said it was dental work.
Yeah.
Like a simple tooth filing. How does fixing a tooth lead to a ball of fungus in your cheek?
Well, it comes down to basic structural anatomy. See, the floor of your maxillary sinus sits directly above the roots of your upper teeth, and the bone separating them is paper thin. So if you undergo a root canal or a deep filing on an upper molar, the dental instruments can accidentally breach that microscopic barrier.
Oh, wow.
Yeah, they can actually push a tiny fragment of dental material like zinc oxide or amalgam straight up into the sinus cavity.
So it's like throwing a pebble into a pond.
More like dropping an anchor in a harbor, really, because fungal spores are everywhere in the air we breathe.
Right.
Usually, our sinus mucus just sweeps them out, no problem. But if a stray Aspergillus spore drifts by and catches onto that tiny piece of foreign dental material,
It has something to grab onto.
exactly, it finally has a solid foundation.
Yeah.
It attaches, it feeds, and over months or years, it slowly layers upon itself until it forms a dense, marble-sized ball.
Wow. Okay, so the fungal ball is just quietly growing. But the second behavioral profile is a completely different beast.
Oh, completely.
It's called allergic fungal rhinosinusitis, or AFRS. And this hits a much younger crowd, typically ages 21 to 33. The key difference here is that it's driven by type 1 or type 3 hypersensitivity reactions. Now, we hear the word hypersensitivity a lot, but what is actually happening mechanically?
Well, it's a systemic overreaction. Type 1 hypersensitivity is what we normally think of as an immediate allergy, like someone eating a peanut and swelling up.
Oh, sure.
The host's immune system creates specific antibodies called IgE, and they act like microscopic tripwires.
Yeah.
The second they detect the fungus, they signal mast cells to just dump a massive flood of histamine.
Which causes the swelling.
Exactly. Immediate swelling, itching, fluid buildup.
And what about type 3?
So type 3 is a bit more insidious. The delayed reaction, where antibodies actually bind to the fungal particles and form these floating clumps.
Clumps?
Yeah, they're called immune complexes. And those clumps get stuck in the delicate mucosal tissues lining the sinuses. The body sees them, totally panics, and sends in heavy-duty white blood cells called neutrophils.
And they fight the clumps.
They try to, but they essentially dump destructive enzymes everywhere. It's basically friendly fire. They destroy the surrounding host tissue, just trying to clear out those clumps.
That makes so much sense. So if I'm visualizing the difference here, a fungal ball is basically a quiet hoarder living in your basement.
Okay, yeah.
Like they just stay in one room piling up their stuff. You might not even know they're there. But AFRS is like the house's internal security system has gone completely rogue and it's actively burning down the drywall just to kill a spider.
That's a great analogy. It works as a baseline, but imagine that quiet hoarder in the basement is also slowly, silently eroding the concrete of your foundation just by existing.
Oh.
It's quiet, but it's not harmless. AFRS, on the other hand, is exactly that chaotic, self-destructive security system.
Right.
In fact, to even diagnose AFRS, doctors have to use strict clinical checklists, like the Benton-Kuhn criteria or St. Paul's criteria.
Oh, I read about those. They need like 5 major positive markers, right?
Exactly. They need to see specific nasal polyps, thick allergic mucin, positive fungal stains.
Yeah.
Because the collateral damage in the sinus is just so extensive.
And the collateral damage creates a very different visual for the surgeon too.
Definitely.
Like during a diagnostic nasal endoscopy, doctors describe the fungal ball as looking like cheesy debris, which is gross.
Very gross.
It's a distinct solid mass. But with AFRS, because of that massive allergic immune response burning down the walls, the sinuses are filled with inflammatory polyps and a substance clinically described as peanut butter mucin.
Yeah, medicine is highly reliant on food analogies, unfortunately.
I don't think I'll ever look at a PB&J the same way again.
I would blame you.
But this brings up a fascinating logistical problem. If a patient comes into the clinic and their head is packed with either cheesy debris or thick peanut butter mucus, how do doctors actually see the battlefield before they physically cut the patient open?
They have to rely on advanced imaging. And because the biochemical environments of these two conditions are so radically different, they yield some very weird, highly specific signatures on CT and MRI scans.
Right, like on a regular CT scan, fungal balls show up with what radiologists call hyperattenuation,
Exactly.
meaning they show up as glowing, bright white spots on the black and white scan because they are incredibly dense.
But AFRS presents entirely differently. The allergic environment creates a distinct visual pattern on a CT scan known as the double density sign, or the rail track sign.
And the underlying reason for that rail track sign is just wild. It happens because there are heavy metals depositing in the sinus cavities, specifically calcium, iron, and manganese. So here's where it gets really interesting. Why are literal heavy metals like iron and manganese just chilling inside allergic peanut butter mucus in someone's face?
What's fascinating here is that while it sounds like science fiction, it's actually just a byproduct of fungal biology. Fungi need trace metals to survive, metabolize, and build their enzymes. So they act like microscopic scavengers. They concentrate iron, manganese, and calcium from the surrounding human tissue and the environment.
Wow, so they're hoarding metal.
Exactly. Now combine that concentrated metal with the intense type 1 and type 3 allergic reactions we just talked about.
The friendly fire.
Right. That chronic inflammation formation dramatically alters the pH balance and oxygen levels inside the sinus. And that chemical shift causes those scavenged heavy metals to literally precipitate out of the fluid and crystallize within the dense mucus.
So it's a chemical reaction happening in real time inside your head?
Yeah, it really is.
And for the surgeon, those crystallized metals act like a giant glowing neon map.
They absolutely do. Because the presence of those metals alters how energy moves through the tissue during an MRI.
Oh, I see.
So the dense metallic fungal elements show up dark in the center of the scan. It's a phenomenon called T1 and T2 central hypointensity. But around that dark core is a brightly glowing ring of inflamed tissue.
Which is known as peripheral enhancement, right?
You got it.
A dark metallic core surrounded by a glowing ring of fire. It tells the surgeon exactly what kind of swatter they are dealing with and exactly where the boundaries of the infection are before they ever make a single cut.
Which is an absolute necessity, by the way. Because the physical removal of this material requires a level of precision that is, frankly, hard to overstate.
Let's get into that eviction process. Once the glowing maps on the MRI have identified the target, it's time for SES functional endoscopic sinus surgery.
Yes, SES.
It's minimally invasive, going through the nostrils with tiny cameras and instruments. But minimally invasive does not mean easy.
Oh, not at all. The entire procedure is governed by intense physiological mathematics.
Yeah, I was totally blown away by the surgical setup. Standard operating protocol dictates that the patient's head must be elevated exactly 30 degrees, not roughly propped up, exactly 30 degrees.
There's a very specific reason for that.
Right, because that specific angle reduces blood flow to the surgical site by precisely 38.3%.
You have to think of the anatomy. The sinus cavities are highly vascular. I mean, they bleed incredibly easily.
Oh, sure.
So when a surgeon is operating through a tiny metal tube using a 4mm camera lens, even a single drop of blood is catastrophic to the vision.
It's like trying to drive a car while someone throws a bucket of red paint on your windshield.
That's a perfect way to picture it.
So elevating the head 30 degrees is basically using gravity to draw up the venous blood pressure. You are draining the swamp before you try to navigate it.
Exactly. The field must be bone dry because the surgeon has to physically navigate what anatomists call the 4 gates of FES surgery. It's a sequential pathway deep into the skull.
Okay, well, walk us through these gates. Gate 1 is the uncinectomy.
Right. So the uncinate process is this tiny hook-shaped sliver of bone acting as a shield for the maxillary sinus.
Okay,
The surgeon has to delicately remove that bone, essentially picking the lock on the first door to access the cheek cavity and clear out the fungal ball.
got it. And once through there, they push deeper to gate 2, the anterior wall of the ethmoidal bulla.
Right. This is getting into the honeycomb-like ethmoid sinuses situated right between your eyes.
From there, they pierce gate 3, which is the basal lamella. That gets them into the posterior ethmoid.
Okay, we're getting deep now.
And finally, if the infection is deep enough, they breach gate 4, the sphenoid sinus.
Wow.
The sphenoid sits incredibly deep, almost at the dead center of the human skull, directly beneath the brain.
The geography of this is just mind-boggling. And the tools are just as specific. Like, to navigate these tight corners, surgeons use things called giraffe forceps.
Yeah, they're exactly what they sound like.
Giraffe forceps. That sounds like a tiny zoo in the operating room.
With these tight spaces and 4 gates, is this basically a microscopic, high-stakes video game?
Pretty much. I mean, they literally have a long curved neck designed specifically to reach up and around the tricky angles into the frontal sinus right behind the forehead.
It's amazing.
And it requires extreme spatial awareness. Before a surgeon even steps into the OR, they must meticulously verify the bony integrity on the patient's CT scan.
Checking for weak spots.
Exactly. They are looking for any areas where the bone might be dangerously thin or already eroded by the fungus.
Because the margins for error are terrifying. You're working inside these tiny gates, millimeters away from the skull base, the optic canal, which holds the nerve for your eyesight,
Yep.
and the internal carotid artery, which is the main pipe pumping blood to brain. If a surgical instrument slips even a fraction of an inch.
You're looking at a cerebrospinal fluid leak, permanent blindness, or a massive lethal hemorrhage.
So given how intense and precise this surgery is, I was really surprised by the factors that can actually cause a FES procedure to fail.
The failure factors are really interesting,
Yeah, things that lead to poor surgical outcomes where the fungus just comes right back. The medical data lists smoking, asthma, aspirin sensitivity, and allergies.
which all make logical sense.
Right, they are all mechanisms of inflammation. But the last factor on the list completely threw me.
Oh, the depression.
Yes, depression. How does being depressed cause a microscopic sinus surgery to fail?
It's wild, right? But it highlights the biological reality of the mind-body connection. We often treat mood disorders as purely psychological, but depression is a systemic physiological state.
Meaning it affects the whole body.
Precisely. Chronic depression triggers the body's stress response system, the HPA axis keeping cortisol levels elevated over long periods of time.
And cortisol suppresses the immune system.
Exactly. It dampens the immune response and drastically slows down cellular repair.
Okay, I see where this is going.
So after a surgeon goes in and scrapes out a fungal infection, that mucosal tissue needs a robust, healthy immune response to heal the raw surfaces and fight off any remaining microscopic spores.
So if you're depressed,
If chronic depression is artificially suppressing that local healing environment, the tissue stays vulnerable and the fungus simply reestablishes itself.
that is incredible. You literally cannot treat a fungal infection in the sinuses without considering the patient's entire biological and psychological state.
Nope, it's all connected.
Though, to give the surgeons an edge, technology is rapidly advancing to make these evictions safer.
Oh, modern FESS is evolving incredibly quickly. Like,
Yeah.
surgeons now utilize CT navigation systems right in the operating room.
It's essentially GPS for the inside of your head. It tracks the instruments in real time, overlaid on the patient's 3D scan, assisting the surgeon so they don't accidentally breach the optic canal.
And they are also deploying drug-eluting stents.
What are those?
They're these brilliant little scaffolds propped inside the newly opened sinus gates, and they slowly release anti-inflammatory medication over weeks to prevent scar tissue from forming.
That's genius.
It really is. And for those difficult areas, we're even seeing the introduction of robotic surgery and the cyberknife for sub-millimeter precision.
Wow. So FESS is a marvel when we're dealing with the swatter behaving itself in the mucus. You drain the swamp, navigate the gates, clean out the peanut butter mucin, and get out.
Right.
But the medical pathways take a very dark, very urgent turn when they describe what happens when the fungus decides it doesn't just want to squat anymore.
Yeah, when it mutates its pH.
Exactly. It fights back, invading the actual blood vessels and bone.
And this is the critical transition from a chronic annoyance to a highly legal medical emergency. It's called invasive fungal rhinosinusitis.
Yeah.
The most notorious example being fulminant mucormycosis.
Fulminant, meaning sudden, severe, and explosive. And this typically strikes patients who are immunocompromised, right?
Usually, yes.
Like maybe they have uncontrolled diabetes or they're undergoing chemotherapy, their immune system's guard is down, and the fungus realizes it can spread. And the speed is terrifying. The invasion happens in under 4 weeks.
Because the fungus literally changes its biological strategy. It stops just growing in the empty space and starts sending hyphae, these root-like structures, directly into the walls of the blood vessels.
Oh my God.
Yeah, and this clogs the vessels, completely stopping blood flow to the tissue. So the surrounding flesh and bone literally starves of oxygen and dies.
Which is necrosis.
Exactly. The fungus then feeds on that dead tissue and just pushes deeper.
So when the enemy changes tactics like that, you can't rely on giraffe forceps and minimal invasiveness anymore. You need heavy pharmaceutical artillery. Enter amphotericin B.
It is the absolute gold standard systemic antifungal.
Right.
But it comes with a massive cost.
Right.
It is incredibly potent and notoriously nephrotoxic, meaning it causes severe damage to the kidneys.
But why does it attack the kidneys if it's supposed to target the fungus?
Well, it comes down to cellular mechanics. mechanics.
Yeah.
Amphotericin B works by hunting for a specific fat called ergosterol, which fungi use to build their cell walls.
Okay.
The drug binds to the ergosterol and violently tears open pores in the fungal wall, basically causing the fungus to leak to death.
Sounds highly effective.
It is, but here's the flaw. Human cells use a very similar fat called cholesterol to build our cell walls.
Oh, no.
Yeah. The chemical structures are so close that amphotericin B occasionally gets confused. It accidentally binds to human cholesterol and tears holes in our own cells.
And the kidneys get hit the hardest.
Right, the delicate filtration tubes in the kidneys are particularly vulnerable to this friendly fire.
So it's a race to kill the fungus before the drug completely destroys the patient's kidneys.
Basically, yes.
And what's so telling about how deadly mucormycosis is the massive protocol shift regarding how doctors administer this drug.
This is a huge change. Historically, because amphotericin B is so toxic and can cause deadly anaphylactic shock, the strict rule was to give the patient a tiny 1.0 milligram test dose.
Right, just to be safe.
Exactly. You would infuse it slowly over 10 minutes and watch their vitals to make sure their throat didn't close up.
But the modern clinical consensus explicitly states the test dose is no longer recommended.
The new protocol dictates that doctors skip the test entirely. They start the patient at 30% of the massive, highly toxic target dose and rapidly escalate to the full dosage within 48 to 72 hours.
And the underlying rationale for skipping that safety check is just chilling. The notes say, quote, delay in giving full dose equals worse clinical outcome. Basically, time is tissue. You do not have 10 minutes to sit around and see if a patient has a bad reaction.
No time at all.
Because if you don't bomb this fungal invasion immediately, the fungus will reach the brain and the patient will die.
And unfortunately, even with aggressive drugs, the fungus often manages to destroy bone before it's stopped.
Right.
And when that happens, the delicate finesse of a FIS-S procedure just goes out the window. The surgical reality shifts to something called a maxillectomy.
Meaning removing parts of the facial skeleton, sometimes the hard palate in the roof of the mouth, sometimes the cheekbone, sometimes the orbital rim beneath the eye.
It's devastating.
So what does this all mean? If a fungus is so aggressive that a surgeon has to remove a significant portion of a person's face to save their life, how does that patient ever function again? Like, how do you chew or speak or look in a mirror?
If we connect this to the bigger picture, this is where we see the absolute pinnacle of reconstructive science.
What's it make?
We don't just leave these patients disfigured. Reconstructive surgeons use incredibly complex procedures to rebuild the human face, using living bone harvested from completely different parts of the patient's own body.
They essentially harvest a bone flap, meaning they take the bone along with its dedicated artery and vein so it stays alive when they transplant it to the face.
Exactly.
And there are three main options used for this. The first is the fibular flap, where they take a piece of the lower leg bone.
Yes. They also use the scapular tip flap taken from the shoulder blade.
The shoulder blade.
Yeah. And the mechanics of why they choose the shoulder blade are brilliant. The surgeon specifically harvests the thicker outer edge, the lateral bone of the scapula, because its natural shape and density perfectly mimic the human alveolus.
The alveolus being the bony ridge in your jaw that holds your teeth.
Right.
Using the rim of a shoulder blade to rebuild your gums. That is mind-blowing.
It really is.
Yeah.
And the third major option is the iliac crest flap, which harvests bone from the hip.
And the hip bone is actually considered the best option when the patient is going to need an implant-retained prosthesis later on. Why is the hip superior for that?
It really comes down to bone density. The iliac crest is made of incredibly dense, thick, cancellous bone. Think about the mechanical forces required to chew food. It's immense pressure.
Oh, for sure.
So if a patient wants artificial titanium teeth drilled into their new jaw, the transplanted bone has to be thick enough and robust enough to anchor those metal posts under pressure. The hip provides that dense scaffolding.
It is just awe-inspiring. It allows a patient who literally lost half their jaw to a microscopic fungal invader to eventually chew an apple, speak clearly, and smile normally again. It's a profound testament to the resilience of the human body.
It perfectly encapsulates the entire scope of this deep dive, from a single microscopic spore taking root all the way to the most complex, multidisciplinary, full-body reconstruction.
So let's wrap up this incredible journey. We've covered a massive amount of medical terrain today.
We really have.
We started with the bizarre reality that a simple dental filing can provide the perfect anchor for a silent fungal ball to grow in your cheek.
Yep.
Then we explored the chaotic, house-burning immune response of AFRS and its signature type 3 hypersensitivity causing peanut butter mucin.
We examined how heavy metals scavenged by the fungus create glowing magnetic maps on MRI scans.
Right.
And how those maps guide surgeons through the high-stakes anatomical pathway of the 4 gates, draining the blood flow to navigate millimeter-tight margins.
And finally, we saw the dark side. What happens when fungi mutate their behavior and invade the blood vessels? It forces medicine to respond with heavy, tissue-damaging pharmaceutical artillery.
Amphotericin B.
Exactly.
Yeah.
And ultimately requires jaw-dropping reconstructive techniques, turning leg, shoulder, or hip bone into a brand new human face.
It is a remarkable narrative of human vulnerability, but also medical ingenuity.
It really is.
Yeah.
And I want to leave you with a final thought to mull over. We breathe in millions of fungal spores every single day. They are in the air we walk through, the dust in our homes, the soil in our gardens, and most of the time our immune system clears them out so seamlessly we don't even blink.
Right.
But just a tiny shift in that balance, a slight increase in stress hormones, or a microscopic fleck of metal left behind from a routine dental trip can turn a completely harmless, invisible spore into an invader that commands robotic surgery and hip bone facial reconstruction.
It's a delicate, invisible balance we walk every day.
Exactly. It really makes you wonder, as you sit there taking your next breath, what else is silently waiting in the invisible ecosystem around us, just one tiny microscopic imbalance away from taking over?
A very sobering thought to leave on.
Thank you so much for joining us on this deep dive. We'll catch you next time.